Hello students, myself Dr. Deptee Warikoo, Department of Physiotherapy, Dolphin PG Institute of Biomedical and Natural Sciences. Our today's topic is Quervain'S tenosynovitis. Quervain'S tenosynovitis is a painful inflammation of tendons on the site of the wrist and the base of the thumb. Let us start the topic. So first, let us have an introduction about the topic. This disease is named after Swiss surgeon Fritz de Quervain, who first described the condition in 1895. It is a tenosynovitis which affects the tendon sheaths of first dorsal compartment of the wrist. It is characterized by degeneration and fibrosis of the tendon sheath. These tendons include the extensor pollicis brevis and the abductor pollicis longus. Let us first discuss about the incidence of this condition, or we could say let us see the epidemiology, how it is existing in currently. It occurs most often in individuals aged between 30 to 50 years. It is about 0.5% in men and 1.3% in women. So it affects women up to 6 times more than men. It is commonly associated with dominant hand. It may be seen more commonly in individuals with a history of medial or lateral epicondylitis. Bilateral involvement is often reported in new mothers or child care providers in whom spontaneous resolution typically occurs once lifting of the child is less frequent. In industrial settings, studies have shown a point prevalence of 8% when wrist pain and a positive Finkelstein's test is present. Let us discuss about the anatomy of these tendons and how these tendons do affect the functional outcome of the hand. These muscles are located on the dorsal side of the forearm and go to the lateral side of the thumb through a fibrous osseous tunnel made of the precious styloid radii and the extensor retinaculum. The pain, which is the main complaint, gets worse with the abduction of the thumb when we grasp any object or ulnarly deviate. So basically we could see that the dorsal compartment of the wrist contains the 6 compartments. First has abductor pollicis longus and extensor pollicis brevis. Second has the extensor carpi radialis longus and brevis. Third has extensor pollicis longus. Fourth has extensor digiti indicis. Fifth has extensor digiti minimi, and sixth is the extensor carpi ulnaris. So the first dorsal compartment is approximately 2 centimeter long here and is located over the radial styloid proximal to the radiocarpal joint. So these are the 2 tendons which are most often affected. Thickening and swelling of these tendons is the most oftenly caused. So one is the abductor pollicis longus, another is the extensor pollicis brevis. This abductor pollicis longus originates from the posterior shaft of ulna and radius and inserts on the first metacarpal base. Extensor pollicis brevis originates from the posterior shaft of the radius and inserts at the base of proximal phalanx. Both are supplied by radial nerve, while the former has an action of abduction and extension of the thumb, the latter performs the extension of the thumb. So these are the 2 basic tendons. These tendons, the sheaths around the abductor pollicis and extensor pollicis brevis, pass through fibro-osseous tunnel. So there is where the main contraction or the compression occurs. If we talk about the predisposing factors, overuse injury, repetitive tasks that involve overexertion of thumb, radial and ulnar deviation of the wrist, arthritis and pregnancy are the basic predisposing factors. It has been, we could say that de Quervain's has been attributed to myxoid degeneration with fibrous tissue deposition and increased vascularity rather than acute inflammation of the synovial lining. This deposition results in thickening of the tendon sheath, painfully entrapping the abductor pollicis longus and extensor pollicis brevis. So what are the risk factors? Age could be a big risk factor if you are between 30 to 50. Gender, as we all know, women are more affected. Pregnancy, baby care, and jobs or hobbies which involve repetitive hand actions could be risk factors. Now what are the activities जो सबसे ज़्यादा affects your Quervain's condition? Like activities which needs repetitive actions like wringing out wet clothes, long use of computer mouse, use of scissors like barbers how they use, or surgical tongs. The doctors are also very commonly affected. Texting nowadays, you call it a hand texting causes this Quervain's disease. Hammering, knitting, lifting heavy objects such as jug of milk, taking a frying pan off and on of the stove, or mother lifting a baby out of a crib. So these could be the things which may affect it most commonly. Now let us discuss about the etiology. As we all know, it is associated with repetitive wrist motions, specifically motions requiring thumb radial abduction and simultaneously extension and radial wrist deviation. The classic patient population is mothers, and the most common cause is chronic overuse. This we all know. Some activities such as golfing, playing piano, fly fishing, carpentering, office workers, musicians can also lead to chronic overuse injuries, and later on you could see Quervain's in such patients, which involves like repetitive grasping, gripping, clenching, pinching, wringing, like these activities. So what happens? The tendon of the abductor pollicis longus and extensor pollicis brevis, which is tightly secured against radial styloid by the overlying reticulum, repeatedly gets injured. Acute or repetitive trauma restrains gliding of the tendon, and there exists the inflammation of the synovial sheath. These two increase the friction while the movement. So whenever you are performing the movement, friction will be increased. Then reactive fibrosis and thickening of the sheet is seen, which later on leads to degeneration, and you are unable to move the thumb. You will start having pain over the thumb whenever the movement is performed, pain will be there. So what are the clinical presentations? The primary complaint is radial sided wrist pain that radiates up to forearm with grasping or extension of the thumb. The pain has been described as a constant aching, sometimes burning or pulling sensation. Sometimes there is visible swelling over the radial styloid process. Swelling is in the anatomical snuff box, tenderness at the radial styloid process, and there is decreased CMC movement. The tendon sheath may feel thick and hard. While there is decreased CMC abduction of the first digit, there could be palpable thickening of the extensor sheath of the first dorsal compartment, and there could be crepitus of the tendons moving from the extensor sheath as you perform the movement. Pain aggravates on grasping, raising objects with the wrist, okay, or wet leather sign could be seen. The Finkelstein's test is positive. It is the most important test, diagnostic test, which is positive and proving that the patient has got Quervain's symptoms. So before going to, we have to perform a proper examination. The evaluation of a patient with signs and symptoms will be done. First, we will have to check the history of the patient. So first we will see the history of the patient. There will be overuse prior to the symptoms, then there could be repetitive activities in their daily work. Pain could be localized over the thumb, and dominant hand will be having most importantly pain. History could also show that the patient, which is a female, could be pregnant or in postpartum stage. So physical examination, patient present with radial side pain typically worsens with thumb movement. The condition may be associated with pain or difficulty on moving the tasks or doing tasks with the hand, tenderness over the radial styloid process, and on palpation there could be thickness, tenderness, and Finkelstein's test will be positive. Now this is the Finkelstein's test which has to be performed in a patient of Quervain'S disease. It is a provocative test used in used as a diagnostic tool. We will have to tell the patient to make a fist when thumb is inside the fist, and now ask the patient gradually perform the ulnar deviation. Take the wrist towards the little finger. The patient will start having pain over the wrist, over the thumb, which will give a positive proof for presence of Quervain'S disease. There are differential diagnosis also. There could be CMC arthritis, scaphoid fracture, Schoffer's fracture, or intersection syndromes. On the basis of symptoms and signs, we could differentially diagnose whether the patient is having these conditions or Quervain'S disease. Finkelstein's test could be the best indicator. There could be extensor pollicis longus tendinitis also of the third dorsal compartment. Again, the symptoms will indicate the presence of the condition. Now, what are the treatment goals? Our basic treatment goals are restoration of the normal painless use of involved hand, resolution of the inflammatory process, prevention of recurrence of the through education, restoration of the pain-free movements, and strengthen the hand. If we talk about the medical management, Quervain'S tendinopathy can be self-limited and may resolve without intervention. For those individuals with persistent symptoms, splinting, systemic anti-inflammatories, and corticosteroid injections are most frequently used. Splinting with a thumb spica brace may offer patients temporary relief, but failure and recurrence are often high and compliance is very low. When we talk about non-surgical managements, so conservative managements, first we could say that medical management with the corticosteroid injections, which is given like this at an angle in the snuff box. Then NSAIDs could be given. And if we talk about non-surgical treatment, the aim of non-surgical management is to reduce pain and swelling. So, physiotherapy management, first important thing is immobilization. Your thumb and wrist with a splint or brace should be immobilized. Therapists do not agree on the frequency and duration of the splint, but some think it should be worn continuously for 4 or 6 weeks. Others say we should wear it only till the pain subsides. Next is the cold compression given for 10 to 12 minutes over the inflamed area. Avoid repetitive or aggravating movements and apply ice to the affected area. This is very important in physical therapy management. Ultrasound therapy, pulsed mode, is very effective and found to be effective for 5 minutes. Phonophoresis with 10% of hydrocortisone is also found to be effective. Gentle active and passive motion of thumb and wrist encouraged for 5 minutes every hour to prevent joint contractures and adhesions should be practiced. Strengthening and stretching exercises after the initial pain subsides is also very effective. Patients may also be prescribed for immobilization for up to 6 weeks. After the pain subsides, you could start off with the movements. Ultrasound, which I told you mainly pulse mode, is thought to improve the treatment outcome and can be used as a diagnostic tool in management of Quervain'S disease. Success with ultrasound guided injections was better than it was reported in the literature and without adverse reactions. So these are the things which are very commonly used. Surgical management is very rare in it and is usually done for those when non-surgical treatment has failed. And if the patient experiences persistent inflammation affecting his or her function, the goal of surgery is to open the dorsal compartment, covering to make more room for the irritated tendons. The opening allows pressure relief of the tendons to ultimately restore pain-free tendon gliding. So these are the exercises, rehabilitation exercises: opposition stretches, wrist stretches, wrist flexions, wrist radial deviations, wrist extensions, gripping exercises. You can use nerve balls, finger stripping, you could use it. So if decompression surgery has to be indicated if there is, as I told you, unsatisfactory symptom reduction. Then after surgery, if the surgery has to be done, the post-surgical care is usually limited. A simple dressing or wrap is frequently utilized with no need for complex wound care. Patients are advised to begin early use of activities of daily living and other light activities. Once the sutures are removed, that is usually up to 2 weeks, you could start off with the activities. Now, how will be the physical therapy management done after decompression surgeries? For first 2 days, immobilization is done within the cast. Active movements of IP joints is done with flexion and extension. After 48 hours of surgery, dressings are removed. After this, begin with gentle active motion of the wrist and thumb. 2 to 14 days, pre-surgical splint is worn for comfort, and active exercises are continued for IP joint, elbow and shoulder. By 14th date, your sutures will be removed. So you will start off doing active activities. After 6 weeks, till 6 weeks, grip and pitch strengthening exercises may begin. Approximately up to 3 weeks, you can progress gradually. By the end of the 6th week, the patient usually is able to resume full functional activities. During these phases, you can also use massage. Deep tissue massage at the thenar eminence can help relax tight musculature that causes pain and could also channelize for the good and connective tissue healing. Ergonomical things are very important. Stretching plays a very important role. Stretching the thenar eminence muscles into thumb extension and abduction can relax and lengthen this tight musculature that may cause the pain. So you will start off with ergonomical management. It features a modeled thumb rest support. This will help reduce the amount of gripping force your thumb needs to apply when you are using a mouse. You could also use kinesio taping technique. This can also help you to decrease pain and improve the function. Patient could be also prescribed for therapeutic ultrasound for early healing. Patient can use power grip instead of pinch. Patient can minimize repetition and rest arm occasionally. Use a light grip tool, pens the mouse, okay, and alternate hand during activities if possible. This is a case study about a female, 45 years old, housewife, had Quervain's in her right hand, and chief complaint was pain at the left thumb and area below the thumb for 20 days. So we had Quervain'S disease for at least 20 days. Vasco was 6 with sharp pain. Doing activities like washing, brooming, cleaning utensils aggravated the pain, and pain ointments and painkillers used to relieve the pain. So we all knew that past history and everything relied towards Quervain'S disease. So while we examined, we saw minimal swelling as compared to the right wrist, tenderness present graded 2 because she was allowing to touch. Then range of motion was affected. So we had thumb flexion, extension, abduction, adduction, strong but painful. Then treatment was giving ultrasound was given 3 megahertz pulsed ultrasound at the ratio 1:4, 5 minutes, intensity 8, and along with this cold compression and ice massage was given, and the patient was advised for rest with some braces to the patient given. And we saw a very positive impact after 4 weeks. So this is about the Quervain'S disease. Home management is very important. So you have to give proper home management program to the patient. Education is very important. Patient has to be educated. Patient has to perform self massage techniques at home, self stretches, and avoid as much as steroids as possible. Splinting are key for success. So keep doing these things. Quervain's is very easy to be managed. Thank you so much for today's lecture, students. If anybody has any doubt, you can contact me on my WhatsApp, my number, or email me. Thank you so much.